So, welcome to the Innovations in Cardiology podcast, where we explore the latest advancements and breakthroughs in the field of cardiovascular health. I'm Dipti Itchhaporia, and I'm thrilled to be your host as we dive into the cutting-edge technologies and innovations that are reshaping the way we understand, diagnose, and treat cardiovascular diseases. Today, we're privileged to have two of leading minds in cardiology join us. We'll be discussing the revolutionary impact of artificial intelligence in cardiology, from AI-enhanced diagnostics to personalized treatment strategies, and how these advancements are transforming patient care. So, without further ado, let's dive in. I'm excited to introduce our first guest. Our first guest today is Dr. Francisco Lopez-Jiminez, a renowned cardiologist and the Director of Preventative Cardiology at the Mayo Clinic. Dr. Lopez-Jiminez is at the forefront of integrating cutting-edge technology into cardiology, including the development and implementation of the AI-enhanced electrocardiogram at Mayo Clinic. His work is revolutionizing the way we understand and prevent cardiovascular diseases, bringing a new era of precision and personalized medicine to the field. We're excited to dive into his insights on how AI is transforming cardiology. Joining us as well is Dr. David Ouyang, a visionary cardiologist and researcher at Cedars-Sinai Medical Center. Dr. Ouyang has made significant contributions to the application of artificial intelligence in cardiology, particularly in developing AI models for echocardiography. His innovative work is pushing the boundaries of what's possible in cardiovascular imaging, improving diagnostic accuracy, and ultimately patient outcomes. So we're thrilled to have him share his experience and expertise and discuss the future of AI in cardiology. So let's dive right in. So Francisco, let's start with you. So first of all, welcome. And I was really interested in knowing how the AI-ECG has been received in clinical practice at Mayo Clinic.
Hi, Dipti. Well, first of all, thank you very much for this invitation. This is really a great opportunity for us to discuss such an important topic. Well, AI-ECG has been received very well at Mayo Clinic since we started implementing this as part of our practice improvement processes. And as we know, in early stages, we have to implement this on the research grounds. And at the very beginning, I will say that many clinicians were reluctant or have some hesitation to incorporate outputs from those algorithms in their clinical practice. But nowadays, we have seen a very high level of acceptance and implementation as people see the value of getting those results. We actually have a system in place that is linked to the EMR, where we see the dashboard with the output of every single algorithm done in every single electrocardiogram. So people can actually go and pick and choose according to what they believe is relevant for each patient. There are differences by perhaps age, the type of clinician, the clinical area people are in, but those things are becoming less and less relevant to determine acceptance and embracing AI.
Francisco, tell us a little bit more about what the dashboard gives us. So I have a patient coming in, I'm there, my patient gets an ECG. What can I see? What's the information I get?
Yeah, the dashboard will say essentially whether or not it will tell you whether or not each one of the algorithms we run for the AI-ECG was positive or negative. And we have 9 algorithms already in place. And for us to put one in the system, I mean, we have many more, but for us to put one in the system, it has to be published already in a peer-reviewed journal. And it has shown or has been perceived as useful from the clinical standpoint. So what clinicians see is the list of the algorithms and whether or not the algorithm was positive or negative, and also the degree of positivity. And that is very relevant because, for example, for a patient that has some shortness of breath and has some personal history of, let's say, carpal tunnel syndrome, and then the amyloidosis algorithm is positive, even if the echocardiogram was completely normal a week ago. If the algorithm is positive, then it will be way more likely that the patient actually has amyloidosis, right? But a completely asymptomatic individual that has no symptoms, 25 years old, runner, zero symptoms, healthy, the algorithm shows barely positive for amyloidosis, I may not put a lot of value to that. So we incorporate Bayes' theorem of, pretest probability determines your post-test probability according to how positive the test is.
But you said 8 algorithms. Tell us about some of what those algorithms are. I think one is about LV function, correct? If they have LV dysfunction, tell us, maybe viewers that don't know.
Sure. The first one was the low ejection fraction. That was the very first one we implemented. Essentially, whether or not the ejection fraction is reduced, and reduced for our algorithm is less than, it's 40% or less. We also have one for cardiac amyloidosis. We have one for aortic stenosis. We have even one for liver cirrhosis based on the ECG, which is very impressive. Some of the most recent ones include the algorithm to detect diastolic dysfunction, DASH, elevated left ventricular and diastolic filling pressure. Very impressive, actually, because as we know, it's a very common condition, and it turns out to be very, very useful. We are working on other algorithms to incorporate one to detect subclinical coronary disease that I believe is going to be another great addition. So, I can go on and on, but those are some of the most relevant ones we have.
Okay, but I'm listening to this podcast and I'm thinking, wow, this sounds really great. I would like to have this at my institution. How do you see this? Is this scalable to other institutions? Is this something that I can get, so that why should you be the only one that gets it at Mayo Clinic?
No, excellent question. So indeed, our dream is that this will be available everywhere, any place, for any clinician. The problem we have, which is the problem of AI, is the how to implement, how to deploy, how to scale. And there are a number of barriers in the process that are, I think, very relevant to mention here. For example, people working in information technology in a particular medical institution will have some specific rules in how and what type of algorithms they are willing to incorporate. So one is at the local level, at the institutional level. Then it comes also the regulatory portion of it. We have FDA approval only for the low EF, and we're working on several other algorithms to get approved. But the process is expensive, is very lengthy. And obviously, that's a limiting factor, because we cannot incorporate this in other institutions until it is FDA approved. And that's, I would say, one of the main challenges. But other challenges include the fact that electronic health systems are not, medical records are not necessarily interoperable. So your Epic might not be the same as my Epic, and you might actually have a different EHR than ours. And that adds more to the complexity. We don't know what is the best way to deploy algorithms like this. Right now we are very liberal in the sense that we provide the results for every single electrocardiogram that is performed in every single patient, regardless of medical history, etc. Right? So the question is that the right way to do it? Do we need this more focus? Do we need a la carte? Do we just apply some algorithms based on what the clinician truly wants? So those are questions that we don't have the answer for, but in the meantime, we are, again, we open the gates of information and AI, and we are essentially seeing and still exploring what is the best way to do it.
So David, this is a perfect time for me to bring you into this conversation. You're very familiar with some of the challenges in integrating AI with all the work that you do and sort of deep learning in cardiovascular. So what do you see as some of the challenges that we face when we try to integrate AI and deep learning into cardiovascular medicine, particularly in clinical settings?
Yeah, Dipti, that's a fantastic question. Even before we start recording, you were mentioning that there's been over 800 FDA-approved AI algorithms. The challenge is that if you look at how many of those 800 or so have a clinical trial, it's close to none. It's a single digit. We've done a prospective RCT of our EF algorithm, but to get FDA clearance is not to do a prospective clinical trial. While that's our bar for therapeutics and medications, devices, the things that we traditionally use as clinicians, but the FDA's bar for software as a medical device is relatively lower. It's retrospective, it's multi-center data, and it's some assessment of, is there rigor in the team that's doing this kind of work? But that said, for a clinician, that's hard to truly assess. And that's why I think there's a lot of friction in adoption at many sites. For clinicians, a lot of the common questions are, does this provide value to my patients? Do I believe that this algorithm works at my site or in my patients, which are unique and special compared to the training sites? And are there financial or reimbursement implications on how we impact patient care? I think those questions are important and real questions, and it really relates to the fact that even after FDA clearance, as Francisco is mentioning, there's still a long row ahead. We have to prove to clinicians that works, hopefully through clinical trial. We have to prove to payers that works, hopefully get reimbursement, and a variety of other reasons why even the integration, we have to work with large incumbents like PAC systems, like EHRs that aren't necessarily the fastest to operate or to integrate new technologies to actually finally get it to clinicians' hands.
So have we made progress in any area that you can point to that says, hey, this is possible? Because it sounds like a long way, and maybe this is all just pie in the sky and a lot of hype.
Yeah, well, I would say that I think Francisco and the Mayo work is a great example with a lot of institutional support. They have this go live. Our EF algorithm, we're hoping to go live at Cedars and Stanford in the next few months. It's already FDA cleared, but it's a long road, and it requires both institutional support as well as, I think, a big body of engineers, clinicians and researchers working together.
What about, is there something that we need to have done at a governmental level support-wise? I mean, what are some of the elements that, in both of you, either one of you can pipe in for this? Because I think this is the sort of crux of it. This is why we haven't, when people talk about the digital transformation of healthcare, why we haven't really done it, it's a lot of the stuff that you guys both mentioned. So how are we going to overcome this?
I think definitely major changes need to occur to the current system in order for AI to be implemented quicker, more widely. But it has to be safe. It has to be obviously with a lot of caution, but caution doesn't necessarily should translate into waiting 2 years or 3 years into getting something approved. Question is, for example, should those algorithms be treated more as a device or more as a test, right? Because the regulatory pathways are different, as we know. And the processes, I think, gotta be more expedited and not to require enormous amounts of money to which is a reflection of the level of evidence that is required, which usually requires this amount of money and time to gather. I think with the progress in information technology, we should be able to gather all that information quicker, faster, cheaper, and for the regulatory agencies to make a decision also faster. Again, I think we learned a lot in COVID, and it will be perhaps a time to reflect on what can we do similar to what we did in COVID, because we were forced to, right? We had a vaccine in 6 months. We had some other, the diagnostic test was developed and approved in a matter of few months. I think we need to reflect on that and see what we can do to that. Again, everything has to be done with a lot of caution, but being cautious doesn't have to be translated into waiting for 3 years for an algorithm to be approved.
David, your comments.
The framework I like to say is the difference between value generation and value capture, meaning that algorithms, in many ways, have very strong clinical validation. We showed that they work well and it provides potentially improved care. But that improved care doesn't necessarily translate to better financials for healthcare system or for reimbursement, right? Our reimbursement paradigm in the US and many other places is not actually based on quality. You don't necessarily get more money if like you get a more precise or accurate diagnosis, but based on throughput. And you can imagine for a lot of AI algorithms, it doesn't necessarily change throughput too differently. The hope is that it improves the care, but that's an area where, you know, is very challenging, and a lot of even value-based care and stuff like that is a tougher framework to really wrap around AI.
So David, what are you working on right now? What can you, and I go back to my earlier question, is there any one thing that you can really point to that's been a success that says, hey, look, AI is really something that's amazing and that we're going to see more of it in the future?
Yeah, I focus on echo or cardiac ultrasound. I think it's the top of the funnel in terms of cardiac imaging. Some of the ideas are similar to what Francisco describes, which are there underdiagnosed or incidental findings that are incredibly important? So we have an amyloid screening algorithm that we are undergoing prospective trialing of, where we identify patients that might have amyloid that were never identified through either the EHR or by the clinician that's reading the echo. We're actually funneling those patients into our amyloid clinics at 4 centers. So this includes kind of collaborators at the Palo Alto VA, Northwestern Medicine, as well as Providence Healthcare. And we're actually having these patients seen, ultimately, hopefully get that diagnosis and hopefully go on therapeutics that improve morbidity and mortality. In the same way, we recently developed an algorithm to screen for incidental liver disease, both fatty liver as well as cirrhosis. And that's something that you can imagine on an echo, we already see the IVC. We already actually have a clear picture. But as an echocardiographer, I've never undergone training to diagnose liver disease. But that actually flags a lot of patients that have a lot of cardiovascular risk factors that might benefit from things like GLP-1s or liver-directed therapies. Those are things that we're really interested in, the prospective implementation and trialing of such technologies.
So I'm listening to both of you. You guys are doing great things, two different, what on the West Coast and sort of middle of the country. How's the collaboration for all of this? Is working together something, or are institutions going to try to do this all alone?
Great question. I don't see AI advancing without extensive collaboration across institutions, collaboration even international, and collaboration with government agencies, national societies, etc. This is another area where we can certainly do better, but I think we are doing a lot of things in collaboration right now. For example, for any algorithm to be approved, it has to be tested in different settings, different environments, different institutions, geographic variability as well. So that requires collaboration. And what we have done for the last 5 years has been partnering with a number of institutions and hospitals and health systems to do that. There is the big question of how much of it has to continue evolving in an agnostic way, how much of it should evolve without necessarily financial interest, but mostly for the goodness of humankind. That's a very strong movement right now internationally. At the same time, the need to identify best ways to make those tools financially viable is gonna be key. I mean, I link this to your question because many times collaboration or collaborators say, well, what do I have here? Well, you will be in a paper. Well, that is not enough. So collaboration is relevant. Some barriers for that, but with the use of cloud-based databases, other tools to do research, I think we can enhance the collaboration for both development, validation, and implementation of the tools. Dave, any thoughts on that?
Yeah, we have a lot of close collaborators. So people like Rohan at Yale, Pierre at Northwestern, Ewan at Stanford, and we oftentimes want to externally validate our algorithms at different sites, like Francisco mentioned, to show that it works in many different populations. Two other things I'd like to highlight is that we are strong believers in open science. So essentially every paper we've published, we release the models so that even without talking to me or without asking for permission, you can download these models to run on your other sites. So we have actually heard from many people ranging from South Africa to Australia to Europe that have been using our models. And we're also pushing really hard to open data. So kind of the largest echo data sets that have been publicly released was work that I've done when I was at Stanford. We've released 200 or 20,000 echoes that really are representative of a lot of the patients that we're hoping to study, and to allow that as a foundation for others to develop AI algorithms.
You know, some technologies that were totally unknown in the clinical research, like federated learning or edge computing, you know, systems that have been used by computer scientists for a couple of decades. We are right now just learning about the existence of those methods that we can actually use to train models in a way that maintains confidentiality, but expands the possibilities to enroll patients from actually all over the world without necessarily breaking any rules, and doing everything according to what is expected in terms of confidentiality. So I think there is a lot of work to do in terms of collaboration, but you know, Dave and I are in a number of groups, and you will see most of the most recent publications at ACC/AHA will include very nice groups of collaboration across, you know, 5, 7, 10 institutions.
So I'm going to ask both of you a question, and both of you need to answer this question. So when people talk about AI and, you know, is it hype or whatever, do you think that AI is going to be transformative of clinical care the way that we're talking about right now? And if so, what's that projected timeline? Are we talking 10 years because of innovation normally takes about 10 years, or is it going to be longer or shorter? So David, start with you first and then Francisco.
Yeah, AI is definitely a transformative technology. I think that it already has and will continue to change how we practice care. As you guys have seen, there's many companies even doing kind of ambient scribes, and how we take notes are already changing. How we interpret the raw data, whether it's waveforms or images, will definitely change. And I think that that's more on the timescale of 1 to 5 years. And I think that eventually, with wearables and with more information, that's kind of ambient information, I think that will tremendously even change the physician-patient relationship in terms of what's being available or when to see a doctor over the 10 to 20-year horizon.
Yeah, I think it is already changing the way we practice, right? And the way we think and the way we embrace this in just 2 years. I think it's a big disruption in the way we do things, and it will continue to be. I think it's gonna be the change is gonna be slower than we think, but the changes will be way more dramatic than what we can actually imagine. What we are doing right now, some of those things we were not even thinking about doing those things right now, even 2 years ago, right? But by the same time, we still feel that everything is moving too slow for the reasons we mentioned before. But, you know, for example, we didn't know about LLMs 2 years ago, right? And right now, all of a sudden, they dominate the conversation about AI. And we are using those things in the EMR already to create some dismissal summaries, to create some automatic text or responses to patients that you can edit, etc. So things that we didn't even think they existed 2 years ago, now they are part of it. It's fascinating. I see this as, you know, as the electricity, the invention of the electricity, the invention of the TV, you know, those radical discoveries that all of a sudden get in front of us, that they can be very disruptive in the good way. They can be disruptive in the negative way, of course.
I just want to say that you said LLM, just for the listeners, that's large language models, for somebody that doesn't know that, like ChatGPT. So, you know, I think that this has been a great conversation, and I really am excited about where AI is going. But if you had to say one thing that we have to do in closing, well, there's two questions I have. One is, if there's a clinician listening and they're not doing AI research, but they're really excited about it, what is your advice to the clinician that's listening that's not necessarily in the AI space, but wants to make sure they stay current? What's the one piece of advice you would give them?
I will say, embrace AI. Embrace AI. Don't be afraid of AI. It's here to stay. And the best doctors will be those who embrace AI and understand AI. Don't feel afraid not understanding much about this. It's a slow learning process, but just don't be afraid of AI. AI is here to be our friend and not our enemy.
At the end of the day, for clinicians, our strength is our ability to understand what's clinically relevant and what impacts our patients. I would say that, as a clinician, I might not know the pharmacology of propofol or other medications that we see being used all the time, but we still use it because we have an intuition of whether or how it works. That relates to AI as well, that you don't necessarily need to program to use AI, but you have to have a discerning eye on, do you actually think this algorithm is providing value? Is this actually correct? And when should you not trust the output of algorithms, right? In the same way that we learn how to interpret lab work, we should learn how to interpret AI outputs over time.
Thank you to both of you for this very, very interesting conversation. I look forward to the future where all of our EMRs have all of this embedded in there, so we all get ECG, diagnostics, and all of the things that will enhance our patient care. So thank you so much to both of you for joining this conversation.
Thank you. Thank you for the invitation.
It's great to be here today.